everyone. Welcome to the IIH Practitioner Series. My name is Dr. Brian Snelling, and I'll be the moderator. So the first lecture in our series is Building a Specialty Practice with Dr. Ricardo Komotar. I'll introduce him here in a second, but first, just some housekeeping items. The Q&A is open during the meeting, so we'll try to keep this informal. So if there's any questions you have, you can either raise your hand and we'll call your name to come off of mute. Or if you have questions that you prefer to type, then type them privately and send them to me. Don't send them to Dr. Komotar because he's not monitoring the chat. And then feel free to connect with each other throughout the event by sharing your name and practice location. And then at the end, we'll have our closing remarks and then talk about the next lecture in the series. But with regards to Dr. Komotar, he is a professor of neurological surgery at the University of Miami School of Medicine. He graduated with a degree in neuroscience from Duke University and spent a year at Oxford in England studying neuropharmacology. He received his medical degree from the Johns Hopkins University with the highest honors and completed his internship and neurosurgical residency at Columbia University, followed by a surgical neuro-oncology fellowship at Memorial Sloan Kettering Cancer Center, specializing in brain tumors. As director of the University of Miami Brain Tumor Initiative and director of the Surgical Neuro-Oncology Program at the University of Miami, as well as being director of the Neurosurgery Residency Program, Dr. Komotar is an internationally recognized leader in the field of brain tumors and performs nearly 700 of these procedures a year using cutting-edge techniques such as surgery and radiosurgery, making him one of the highest volume brain tumor surgeons in the world. So how that relates to our IIH Practitioner Series is with a disease like IIH and novel treatments for that, we're trying to explore how practitioners can build a practice around using some of these new techniques. And there's really no one better than Dr. Komotar to help us bridge those two worlds. So Rick, thanks for being here.
No, absolutely. Thanks for having me. Let me share my screen. Perfect. Can you guys see that?
Yes.
All right, cool. So yeah, I mean, just like Brian said, the title of this talk that you're seeing says Building a Brain Tumor Center, but this is really applicable to all fields of medicine, especially when you're talking about a specialized condition such as IIH. I think that programmatic development is kind of uniform amongst those conditions. And so what you're going to be learning about today, again, even though it's centered around brain tumors and what we did here at the University of Miami, these principles are really applicable to any medical practice and especially niche practices like the ones that we're going to be speaking about. So I guess the first thing to understand is what is a medical practice, right? What's the definition? It's using your knowledge to treat disease. And then for us, it's really the volume of patients that you're going to be taking care of. And I think the same thing when you're talking about IIH, right? What is a medical practice around IIH? And that's how many patients with this disease are you evaluating? How many are you treating? So why is it important to have a medical practice, right? Many physicians strive to do it. You know, what is the benefit? Is it worth the time and effort? And I think that the major take-home point that you'll be learning today is that building a practice, regardless of what specialty you're in, takes a lot of time and it takes a lot of effort. It's not really given to anyone. And as I said, not taught during residency. You spend, at least in neurosurgery, you spend at least 7 years, probably 8 or 9. And at no point in time in your residency do you actually learn the business model. Do you actually learn how to build a practice? And yet it's just as critical as any technical skill that you learn. The actual business part and really how to get those patients, how to build that program is just as important. So what are the benefits to building a high volume practice? Again, regardless of what you're in. Well, private practice, it's very clear. It's your revenue. You are running a business. The more patients you see, the more patients you operate on, the more patients you treat, that is the fuel that's going to run your enterprise. But in academia, it's a little bit less clear, right? Many of us are on salary, not a direct financial correlation. And we all know that there's doctors who can survive in academia despite being quote unquote in the red. So the main question is, why build an academic practice? Like I said, mainly salaried, not a direct, clear financial incentive. You've done all your work as a resident and fellow. Now's the time to relax. And I remember being a resident saying that I would never work as hard as as I did as a resident once I'm an attending. And I can tell you that I've worked harder. I think being an attending, and when you're responsible for your own practice and you want to build that business model, that takes work and it takes effort. And so that's really the focus of the next part of the talk. So I think if you're going to remember one slide in this talk, this would be it. And that is that volume is power. And what exactly does that mean? And by volume, I mean case volume. How many people are you seeing? How many people are you treating? Who are you operating on? So volume is going to be expertise. So just like playing a sport, if you play golf once a month, you're not going to be nearly as good as if you play it every single day. Same with surgery, same with any specialty condition. If you're seeing these patients often, you get more comfortable, you have better outcomes, and you become a true expert in that field. Volume is going to be training. So if you're going to produce the next generation of leaders in that field, your trainees need to see that condition early and they have to see it often. Volume is going to be data. It's going to be research. It's going to be clinical trial. If you want to push the envelope with pseudotumor and you want to advance the field, you need data. You need to take care of patients. That's how you have clinical trials, and that's how you have cutting edge research. Volume is going to be reputation. So if you treat this condition often, you generate that reputation, and then that generates more volume once you hit a critical mass. And finally, volume is going to allow you to build institutional and programmatic support. Anytime you're trying to start a center of excellence, be it in brain tumors, be it in pseudotumor, be it in whatever, the volume is what is going to have your hospital and your institution back you. Everyone starts a program and they always have a lot of asks. I need more clinic space. I need more resources. And at the end of the day, the hospital only has so much to give. And if you're a low volume practitioner, you don't have their attention. Meanwhile, if you're generating high volume and you're generating revenue for the hospital, you now become a priority and you can build that program the way you want. So my suggestion would be anyone starting a program, you don't want to ask and then produce. You want to really produce and then ask. You'll have much more success, because if you don't produce, really the hospital is not going to be listening to you, any of your requests. So how do you build volume? Again, that's the major part of this talk. Very complex, hard to kind of cover in one talk, but we'll go over the basics. As I said before, the number one thing is it requires work. I can't tell you how many physicians get to a job, they want to start building a practice, and they just want the patients to come to them as if that's going to automatically happen. Really building a practice, building volume, building that referral base takes a lot of work, and it's everything outside the operating room, at least in neurosurgery. I always tell our residents and fellows, surgery is the easy part of our job. You're in there, you're operating, you're with the residents and fellows, no one can really bother you. So that's the easy part. And if you go to work and you operate and you go home, very difficult to build a practice. It's everything that goes on outside of the operating room that is so critical towards building a practice. And the way to look at it, again, what I tell our residents and fellows is many options out there. A lot of people do what we do, many talented options. Why should patients come to you? And I think it's no different when you're talking about treating pseudotumor. These 3A's drive any referral pattern, period, plain and simple. Availability, affability, and ability. Number one is availability. You have to answer your phone. In the year 2023, fax is irrelevant. Working through your office is irrelevant. If you're going to build a practice, people have to reach you through your cell phone. Many people don't like the idea of having their cell phone on them at all times. That's just it, the way it is in the year 2023. And so number one, you have to be available. If you're not going to be available, everything else kind of falls apart. Number two is being affable. And by that, it just means you have to be pleasant to people. People have to like working with you. You could be the best at what you do, but if people call you and you're curt and you're not pleasant, people are not going to want to work with you. So again, you need to be pleasant when you interact with your other colleagues. And last, and actually least important, is how able you are, which is kind of remarkable. We all know a lot of surgeons, at least, who aren't very good at surgery, but they're very busy. That's because they are available and they are affable. Now, if you can land all 3A's, that's when you can really build a truly monumental practice. So we're going to talk about building a practice and how to build a program and really go over all of these key steps, which I think is very important towards building a true center of excellence. And we're going to talk about it in the context of the UM Brain Tumor Institute, which started back in 2012. Back when I got here, the goal was to build a center of excellence, a true comprehensive brain tumor program. What were the challenges? We really wanted to start a fellowship, train future leaders, bring in surgical innovations that were on par with other leading brain tumor centers in the country, start a brain tumor bank and database, which is absolutely critical towards any brain tumor center, clinical trials and translational research, and finally, case volume. As I said, your number one priority, if you're going to start a program, is to build volume. You need the patients to come to you before everything else falls into place. So what did we do here at UM? Again, many challenges. There was a small ER. There were really no guaranteed brain tumors coming through the emergency room, as opposed to Jackson Memorial, which is across the street, where there's 1 or 2 operative brain tumors coming per day. We didn't have that guaranteed volume that was coming in where we could kind of launch off of that guaranteed volume and then get the elective patients. No experience with brain tumors. So the nurses, ORs, techs, consultants in the hospital had never dealt with a brain tumor. That's both a good and a bad thing. It's bad because you're starting from scratch. That's also a good thing because you can build a program exactly the way you want it without having to change all the prior managed ways that they would do it beforehand. And finally, it was a private hospital. It was called Cedars Hospital. Breaking those networks of referrals was very, very difficult. And you'll see, if you're trying to build a specialty practice, you have to figure out where people are currently sending those patients and somehow draw them to you, make it more enticing. Either you're more available, you're more affable, or you're more able, hopefully all three.
Hey, Rick, a quick question from the chat,
Sure.
if I don't mind. So with regards to your cell phone, can you just touch on 2 things? One is, I'm assuming when you say giving out your cell phone, you're talking about referring doctors both in your hospital and outside. How do you deal with patients that want to be in constant contact with you?
So definitely do not give out cell phones, because at some point, time is finite, and email is a really nice, happy medium. Text and phone calls, I give, cell phone goes out to doctors because they're not going to be intrusive. Patients can be very intrusive, unfortunately, and you have to set boundaries. And I think email is a very happy medium where we all check it several times a day. So the message will get to you,
Right.
but it's not pinging, it's not calling in the middle of the operating room. So email is the way to go.
Gotcha. Thank you.
No problem. So the first step towards building a program is targeted faculty recruitment. If you're going to build a center of excellence, your first hire has to be a clinical workhorse. Any center of excellence is going to require multiple components. You need the clinical component, you need the administrative component, you need the research component. All that stuff is critical and you need it, but it can't be your first hire. Your first hire needs to be someone that is 100% focused on expanding the clinical volume. And then, as I said, once you build the volume, the hospital, the program, the university, wherever you're working, they're going to be much more supportive. So focus on the volume day one. First hire has to be a true workhorse. Then you need to build that network of referrals around your community. And for us, this is back in 2012, back when we started the University of Miami Brain Tumor Initiative, we needed to raise awareness of this program. Doctors need to know what you're offering. You can't just expect them to know, because much like any consumer, you have to educate them. So we went on a mission to inform South Florida physicians about the Brain Tumor Institute. So we Googled South Florida hospitals. There's actually 92 hospitals between Key West up to the Treasure Coast, out to Naples. Some are small psych hospitals. Other ones are larger, like Baptist and Mount Sinai. But again, all these hospitals matter. And so what did we do? We contacted each and every one of these hospitals. Every single facility has to have a CME event. It might be Grand Rounds, it could be Tumor Board, it could be Journal Club, but every hospital has to have some type of CME event. And so we asked to speak at whatever event that was. Again, Grand Rounds, Tumor Board, CME. And 77 of these hospitals said yes. So we gave 77 talks over 18 months. And this is the work component that I was talking about before. If you're trying to build a pseudo tumor practice, or you're trying to build a niche practice in anything, you have to educate your consumers. Those consumers are those referring physicians in the area. So that doesn't happen overnight. It doesn't just fall into your lap. 77 talks over 18 months. I mean, do the math. It's a lot of time, energy, effort spent on kind of a grassroots effort. And that's really the take home point. It starts with the practitioner. It starts with the doctor. You don't turf this to your ancillary staff. You don't turf this to your administrators. This has to come directly from the physician. So what did each talk emphasize? Again, this is going to be different depending on what you're doing, but for us, it was the 3 A's, what we were doing differently, surgical innovations, techniques that weren't necessarily allowed out in the opportunities with the private practitioners. What were we doing that was cutting edge? And so this is the part that I was saying, you somehow have to entice these people to send you patients. Why is it better for their patients to come to the university or to any center of excellence as opposed to their traditional referral base? I'm not going to bore you with this, but these were the surgical techniques that we brought over to the university that really separated us from the other hospitals in the area, and this helped us generate volume.
Rick, can I interrupt you there? Can you just go back to that slide for 1 second? Sure. I think this is an important point for, if you think about like a neuro-interventionalist that's coming out, they've got some training, they may or may not have learned venous sinus stenting in their training, and they may do some of it for IIH. So, the way I've always thought of something, there's sort of like tools in the armamentarium, right? You just need to have that as another tool that you can help not only to build your volume, but to help patients. So how do you think about, or how do you like couch these new technologies or these new innovations to whether those are neuro-oncologists or referring doctors, neurologists? Like how do you bring how do you talk about new things that you can offer that other people can't? And how do you think that helps both your volume and your practice?
So I think that these technologies, patients seek cutting edge technology. And so this is the face of your practice. And so, I think the best example would be laser ablation. Laser sounds sexy, it's super cutting edge, and patients come to me for the laser. But for every 10 people who come to me saying, I want the laser, only 1 is really eligible. So 9 of them get a conventional craniotomy and 1 gets the laser. So I would say that these techniques, each of them may not be generating volume by itself, but as a whole, like you said, if you're offering a real center of excellence, you have to offer all of the latest and greatest because patients will seek that out. And even if they don't know what they need, they'll hear about venous sinus stenting and be like, wow, sounds cool. They'll go to you even if they don't need it. And then they're part of your volume. And then you'll make the right decision whether or not they actually need that technique or not. So I think that anyone who's going to be a true expert in the field, you need to offer a broad spectrum of technologies and techniques because that's what patients will seek. And that's really the doorway into your center.
Got it. And then for some of these things, did you have all of that training in fellowship, or were there certain things where you were like, man, laser ablation might have come along, or some of these techniques they came out afterwards? How do I, do I need to be one of the first adopters in bringing those technologies in?
You have to be open to early adoption, 100%. I would say laser ablation, Vicor, fluorescence, robotic guided stereotaxy. I did none of that during my training, none of that. I was a junior attending when laser ablation came out. We were one of the first adopters, and everyone's like, oh, it's not proven, it's not proven. And my answer was, we want to create the data, not wait for the data. And so I think any practitioner, if you want to be cutting edge, you have to be open towards new technologies. And just because you weren't trained in it and it's not conventional, if you start writing things off, then all of a sudden status quo becomes okay and you stagnate. And no matter what the field is going to be advancing at a very fast rate. So if you're not advancing, if you're doing the same things now that you were doing 10 years ago, you are by definition falling behind, because medicine, and especially if you're talking about, the stuff such as pseudotumor and neuroradiology, neuro-interventional radiology, that field is progressing yearly. So again, you got to take a look back. And if you're not pushing the field forward, especially in a field like that, you are going to become antiquated within 5 or 6 years.
Thank you.
So then again, each talk, what's the most important part of the talk is how to get in touch with you. You can give the world's greatest talk. You can go over all the technologies and all this cutting edge research, but if they don't know how to get in touch with you and they have to call some central scheduler, that's going to be a huge roadblock and that's going to kill your volume. So the last slide of the talk was always about how to get the patient seen and what is the personal contact information for me directly, not my office, not my staff, but my cell phone, my email. then you need to reach out to the community. So it's one thing to have the doctors know who you are, but realize that many patients get referred through these support groups. And I think that IIH is no different. There are support groups and patients will reach out to these groups and they will make referrals. And so these are the 4 big brain tumor associations. And what did we do? We met with them. We spoke at their gala events. We got on their board of directors, and we get dozens of referrals a year where there'll be a brain cancer patient or any brain tumor patient, and they go to the PAPCOR or they go to Voices Against Brain Cancer, and they'll be like, go to the University of Miami, go see Dr. Komotar, Dr. Ivan, Dr. Shah, whoever it is. And so you got to plug yourself in. You have to think outside of just physicians, but these support groups in any disease play a huge role in where patients first get their information and 2, where they get referred to. Then you got to look at what is your catchment area. So again, it really depends on what your specialty is. But if you're trying to build a practice, you have to look and see what are the gap zones. Where is the best potential for growth? And you have to do research, right? You don't want to spend your time marketing and giving talks in an area where your group is already dominating, because you're not going to get much out of that. So for example, we didn't spend much time looking at Dade County because we already had a large chunk of that brain tumor volume. Broward and Palm Beach, early on I got here, and it turns out that every single patient, nearly every single patient in Broward and in Palm Beach was being diagnosed with a brain tumor, and they were flying directly to Duke. They weren't getting a second opinion at the university. They weren't going locally. They were literally getting on a plane and flying to Durham. And not that Duke's not amazing, but there's great options nearby. And so the fact that patients were being diagnosed and immediately being referred up to a different state, that's a huge potential for growth. So all of our effort was really focused on Palm Beach and Broward because that was the biggest gap zone for us. So now you need to facilitate referrals. So you've marketed, you've identified gap zones, you've spent your time in that area educating physicians, educating all these support groups, but now it's time to facilitate those referrals once they start coming in. There we go. Again, it's not enough that people know about you. If they know about you, but they can't get in to see you, then there's no benefit at all. So again, got to be available. This is the year 2023. Office is irrelevant. Fax is irrelevant. It's got to be cell, text, and email. The most able doctor, as I say, doesn't always get the patient. We'd like to think that the best doctor gets the patient because that's the best care. That is not the case. The most available doctor will always get the case. Hopefully those 2 go together. But it's not enough that you're available. Let's just say someone calls Brian and they want to refer Brian a patient. He needs to make that referral seamless. So if they call Brian and like, hey, Brian, I need you to see this patient who has pseudotumor. If Brian's answer is have them call my office, that's the wrong answer, right? That doctor could have gotten your number on Google. They've wasted your time. You've wasted their time. Now they're going to call some central scheduler. God only knows when they're going to get scheduled. And you don't control that referral. When they call you, and this is probably 90% of my referrals, the answer needs to be sure. Give me the name and number, and my office will then expedite. Now you control that referral. That doctor feels good. They've gotten that patient off of their lap. They're now with a specialist, and you can never lose that patient. Now you have the information, and you can forward that to your office, and your office can then expedite the appointment.
Rick, can I ping you on two things there? So one is that when you get that referral that comes directly from the physician, you say, okay, well, give me the info, we reach out, and you're giving that to somebody who you trust and you've trained to do. I'm assuming to do what they have this sort of the same goals you do, and they sort of are responsible to you. But what about for those patients that maybe just call like a general number? How do you maintain oversight of patients that may get your number off of a website or hear about you from a friend and may not come through a referring doctor? How do you ensure that those patients are getting that same that same standard of care, and that you're closing the loop on those patients?
So you have to have, and so in that case, you really need to rely on your office staff. If it's a direct referral from a physician, the answer is always kind of what you're seeing here on the screen. If someone calls a general scheduling number like they would here at the university, and they ask for Dr. Komotar, my staff knows what diagnoses do I see and what do I not see. And I border on being generous, right? So, if you do something but not a lot of it, I still put it down. You can always weed out those patients later. But your office staff has to know that if someone calls my office and it's like, I want to see Dr. Komotar for a spine issue, my office knows that I don't do spine, and they will not schedule them. They will then refer them to one of my colleagues. So I think if someone calls a general number, your staff needs to be very involved and has to know what you do and do not treat. And if it's from a referring physician, then the answer is always like this. If a physician refers you a patient that you don't treat, which happens to me a lot, they'll send
Right.
me a patient who has an aneurysm or a spine problem. I also refer those to my colleagues. So you have to be able to kind of triage and help these physicians out.
And then one other thing that you mentioned, you just mentioned it briefly, but I think it's a really important point, especially for IIH, is that a lot of times these referring doctors, whether it's a neuro-oncology condition or what, they have a patient in their office, and that they need an answer of what to do with them. And so really you're helping them out. And so I think there's really not a condition that's truer for than a patient with IIH. It's a very nebulous condition. It can present a lot of ways. And by being available, you're really offering them a way to, you're solving their problem, which I think is a way that they're really grateful for, and that'll keep those referrals flowing to you.
Correct. It's a business. At the end of the day, medicine, we don't want to talk about it as a business, but it is a business, and you're offering a service. And so if you're offering white glove service, red carpet service, you're answering the phone, you're getting patients in, that will generate a tremendous amount of volume, in addition to being a good physician. If you don't offer that service and people have trouble getting into you, and your office is rude and you're rude, but you're the world's greatest physician, you won't have any practice. So it's important to realize that it really is a concierge type of approach that you have to have with any practice building program. So again, now you got to expedite those appointments. You've gotten the information, doctors have sent you patients, but now you have to expedite those appointments, right? So for me, all patients are seen within 48 hours, all new brain tumor patients. I see patients 5 days a week, often in between surgeries. Again, it's different, I think, when it comes to brain tumors, because people with brain tumors will not wait. They can have a tiny benign brain tumor. It's incidental, it's asymptomatic, but to them, they just got the craziest diagnosis in the world. And if you don't see them soon, they're going elsewhere. They're going to leave the state, So I would say that you need to, at least when it comes to brain tumors, understand that these patients are scared. You got to see them right away. And if you delay seeing them, then you will lose half the referrals. And I think pseudotumor is very similar, because these patients can be losing vision. They can have, devastating headaches. And so every day that goes by, even if you're the world's best at pseudotumor, if you're not able to see a patient for 2 weeks, they may go find someone who has a lesser reputation, but will see them right away. So again, white glove, red carpet service. Now, fostering collaboration with the community. This is very important anytime that you're in academia. The point is that the majority of patients arise from the community. Being in academia, I can tell you it's very easy to kind of silo yourself off. Many of my colleagues do, and they rely only upon referrals from within the university. And while that's the easy way out, you have to realize that the majority of patients in any condition, whether it's IIH or brain tumors, the majority of patients come from the community, not from the university. The university it really is a very small proportion of those referrals. And so the goal is to integrate your academic center with the community. Once you do that, that's when you can have a really explosive growth. And if you think about it, most physicians are going to want to send to university because they have the best techniques and they have the most cutting edge research. But really, what are the roadblocks? People don't know who to call. Once they call and they're scheduled 3 to 4 months out. At least it happens here at the university. Once someone is seen, there's no communication, or there's some ghetto fax that gets sent to your office that you read 3 months later. And then there's really no continuity of care, meaning that people will be referred into the university, they'll be treated, and then they'll stay in the university. And that's the black hole effect. And you really want to avoid that. So, what do I do is that I try to overcome these roadblocks, always available. So people call my cell phone. They don't call the university number, which is central scheduling, and it's awful to deal with. Easy access. Everyone gets in within 48 hours. constant feedback. Every patient I see, I know the referring doctor, or I find out and I send a quick text. Saw your patient, this is the deal, surgery, no surgery. And then the patient always goes back to the referring physician. That's really practice building 101. Just like you're trying to build a practice, so is every single physician out there. So if someone refers you a patient and you treat them and then keep them within your healthcare system and they don't go back to that referring doctor, that's a practice killer. And that's really practice building 101. If someone sends you a patient for whatever condition, at least offer that patient or at least offer that doctor to see that patient again. Many times, I'll see a glioma. It'll come from the community. I'll talk to the neurologist. Hey, do you want to see him back? No, thank you. Very complicated patient. Keep him at the university, do clinical trials. Great. At least you've offered that. But many times I'll take out a metastasis. It was sent to me by a, medical oncologist, radiation oncologist. It goes back to those doctors. I could easily keep it here at the university, but that physician's never going to send me a patient again if I steal their patient, essentially. So again, patient always goes back to the referring doctor. If you can overcome these roadblocks with these solutions, and you can integrate the academic center with the community, that's where you have an exponential growth in case volume that we had here with our brain tumor program. So you got to network. Again, just like any other business, growing a practice is about networking. Many ways to do it, many kind of correct ways to do it. I store my contacts on Outlook. That's what we have here at the university, but any of those cloud-based systems where you're not going to have a crash and lose everything is fine. Currently at about 8,000 referring physicians here in South Florida. And having these contacts allows you to constantly update referring physicians, email and text. Pre-op, I saw him in the office. Post-op after the surgery. Follow-up 2 weeks later. MRI collages. I have my fellows and residents put together images pre and post-op, what the brain tumor looked like before, what it looks like now. That loops in the physician. They know what was done. They feel like they're part of the team, which they are. Can't say it enough. FACS is pointless. Anyone who's asking for a FACS is living in the year 1995. We don't even do FACS. I don't even know if I get FACS. So please do not rely on that. That will not build a practice in any way, shape, or form. You got to open up these lines of communication, texting, email, form relationships, and network with these physicians. That's how you beat out your competition, because wherever you are, whatever practice you're trying to build, your competition is going to take the easy way out, and they're going to rely on FACS, and they're going to rely on a central scheduler. Bypass FACS, bypass central scheduling, and you will annihilate all of your competition because no one else is doing this. So this is just a quick example of a text that I would send out post-op day 1. Joe Smith doing well, no issues, neuro intact, home today. MRI confirms gross total resection of his large bifrontal meningioma, Rick Komotar. That took me 10 seconds to dictate. My fellow put this together within 2 or 3 minutes, and I send this to the referring physician. They know exactly what's going on. There's an impressive image. They know their patient is doing well. They are part of the team. This referring physician will never send another patient anywhere but to you. Not only did the patient do well, but you think any other doctor is sending him this? Absolutely not, because no one's willing to put in the work. So they get this. It's better for patient care. It's continuity of care, and it helps build your practice. So this is an example of kind of what networking will do. This was a patient who came to see me from 6 hours away. This is like north of Orlando. And they came to my office and they brought an MRI report, 1, large right-sided mass, 2, go see Rick Komotar. Like in the MRI report, I'd never seen this before. I was kind of blown away. And this goes to show you the powers of networking. When your reputation grows and you network with doctors, people will then send you patients. And this is coming from ground zero. This is coming from the MRI center. I didn't know the radiologist. I didn't know the neurologist. They just referred the patient down to me. And you're never going to lose this patient because it's on the MRI report. You're not relying on the primary care doctor. You're not relying on the neurologist. It's in the MRI report. This patient is locked into your service. So what did I do, right? I could have just looked at this, felt good about myself, and then thrown it away. No, what did I do? I called this MRI center. I spoke to this radiologist. I got his name and number. I kept him posted on the case. I told him it was a meningioma or a met or whatever it was going to be. I updated him. He was grateful. I drove up 6 hours up to Orlando and gave a grand rounds talks to this group. This happens to be the largest MRI center in Florida. So I spoke to about 20 neuroradiologists, and what do they do now? Every single brain tumor that comes through the largest MRI center in Florida, it says, go see Rick Komotar. So no better time spent than educating these physicians that, look, if you get an MRI and you see a brain tumor, they will dictate, go see Rick Komotar. And it's a direct pathway coming from ground zero at the time of diagnosis. So this is not applicable to everyone, but it kind of emphasizes the point that building a practice is very little to do with how good you are and a lot to do with marketing, effort, networking, and the stuff that most doctors are not willing to do. So step-by-step new patient referral, everyone does it differently. This is the way I do it. So probably 90% of my referrals, I get a call, text, or email. Many of the physicians, because I've been doing this now for about a decade, know exactly how I like the referral. So I'll just get a text and it'll be from Dr. So-and-so. It'll just say John Smith, meningioma, and a number. That's it. And that's all they have to write. And I just write on it and I forward it to my staff. So I get the name and number, I forward it to my staff. My staff knows the deal. Everyone has to be seen within 48 hours. I see the patient, I then make a plan. I get back in touch with that doctor, email and text very quickly. Saw your patient, benign meningioma, asymptomatic. We'll see them back in a year, no surgery. Or surgery next week, malignant glioma, blah, blah, blah. Email and text after surgery, email and text upon discharge with the MRI images, email and text upon follow-up in the office. And so this seems like a lot of work, and it is. I'm not trying to downplay the amount of work, but if you're disciplined and you're organized, and this is a priority, you can definitely do this between 9 to 5. Most of this stuff I do as I walk back from the operating room. Social media, internet presence, this is reality. Again, in the year 2023, many doctors don't want to do social media. I can tell you, I was reluctant back in, I think, 2017 when I started it, thinking that that's for young adolescents. It's not for adults. This is business, and your internet presence and your social media presence is important. This is the face of your practice. So you have to get out there just like any other business. So many options in terms of what's available on the internet: Health Grades, Press Ganey, Instagram, Facebook, Twitter, university webpage. What is your own personal professional webpage? I advocate picking one social media avenue. I don't think you should do multiple because it really does take a lot of time. I would pick Facebook or Twitter or TikTok or Instagram. I pick Instagram and I would just focus on that. You have to have at least one strong social media presence. And then many people will say, well, what's the purpose of being online? What's the purpose of it? Why is it so important to have your university webpage or your professional webpage up to date and full of information? And I would say this is that shopping for a doctor is much like shopping for a bottle of wine. I know nothing about wine. I go to a store, I look at the wines, the one with the coolest bottle, I'm like, yeah, this looks good, and it's usually terrible. But I would say it's no different than when a patient shops for a doctor. If someone gets referred to Rick Komotar or to Brian Snelling, what is the first thing that any human being on the planet Earth does? They Google you. It's the first thing they do, right? Maybe back in 1985, no one was Googling, but in the year 2023, people are Googling you. They're going on your social media and they're going to evaluate you before they see you. And if they go to Brian Snelling's webpage, even though we all know Brian is an amazing neurosurgeon, if they go to Brian's webpage and it says Brian Snelling, neurosurgeon, without any more information, they're going to be like, this dude's kind of whack. Like, I'm not going to go to him. I'm going to go to some other doctor that has an awesome webpage, even though it could be full of lies. So what I'm saying is, obviously don't lie, but your internet presence has to reflect the kind of physician that you are, because that's the face of your practice. So if you have a big publication, put that on your webpage. If you're doing some cutting edge clinical trial, put it on your webpage. If you're using a new technique, like we were talking about, venous stenting for pseudotumor, put that on your webpage. Like, otherwise people are not going to know. So again, invest the time, make sure that your webpage and your internet presence, including social media, does reflect the interesting cutting edge stuff that you're doing.
Rick, can I just with regards to the professional webpage, you mean actually taking it upon yourself to build or have built out your own personal page, not through your employer, correct?
Correct. So it depends on who your employer is and how restrictive they are with their webpage. So the University of Miami became a little bit less strict, and I think their webpage is pretty good right now, but they have a template. You can't violate the template. Everything is very cookie cutter to them. Every physician is the same, which obviously is not true. So I went ahead and I started my own webpage so that I could advertise better. I could put what I'm doing, but I could put a better face forward. So I would say that, if your hospital or your institute or your university, wherever you're working, if they're very restrictive and they're not allowing you to put together the kind of page that you think you deserve, then it's definitely worth spending a couple $100 a year. I think it's like 200 to have a professional webpage that you can then, have at the standards that you feel are necessary.
Yeah, I agree with that. I think we've had similar issues. At least the thing that was always an issue for me was that they can't treat you any differently than they treat any other physician in the program. So,
Right.
If you really want to have like a superlative website that focuses on all the stuff you do, you want to have videos and like you said, take it to the next level and be that first link that comes up when patients Google you. You really have to take that upon yourself, and you can't rely on your hospital media or marketing department to take care of that, because they really can't treat you any differently than any other physician in the group.
Correct. And again, doctors are going to be initially, I don't have to do this. This is marketing. I'm a physician. This is all noise, they believe. I mean, this is reality, and doctors have to take it upon themselves. And this is why I say that none of this is taught during residency, but it's critical. And I tell our residents and fellows, the moment they get here as an intern, they should start a professional Instagram page and put up cool surgeries that you've done, great outcomes that you've had, interesting MRIs. Start building that repertoire, because I really do think social media is not only here to stay, but I think it's going to be the number one way that physicians get evaluated is by social media. So you can complain all you want. It's reality. Get on, either get off the tracks or the train's going to run you over. Superior clinical outcomes. This, at the end of the day, this is what we're all looking for, right? Patients will be your biggest referral source. Everything I said is important, but in medicine, especially in the year 2023, with so much social media, everyone knows someone who had neurosurgery or who had pseudotumor or who had any condition that we're talking about. So patients will be your biggest referral source. So keep patients as your first priority. It's very easy to get lost in today's world where there's so many different avenues for your time: administrative, educational, research, all that stuff's important. But the reason why you went into medicine is to take care of patients. And so number 1, 2, and 3, patients need to really be your priority, no matter what your other activities are. Keep complications to a minimum. So I can't emphasize this enough, but your reputation as a surgeon is formed in the first 3 years of practice, period, plain and simple. You can come out of a great program, come out incredibly well-trained. You're a little bit too cavalier. You have a couple of avoidable complications early on. People label you a hack. Very difficult to get rid of that. Conversely, you come out, you're safe, you're doing conservative surgeries, your overall outcomes are excellent. People are going to give you carte blanche. They're going to label you a great surgeon. And then that's a much better way to kind of launch your career. Keep outcomes favorable kind of ties into there too. Your outcomes as a surgeon, your patient satisfaction as a physician, that's your cachet. That's your currency. That's the way you're evaluated, right? People get R01s and they do research and they get promoted and they're administratively great and they can be a chairman or a program director. All that's great. But if your outcomes aren't favorable, you're not a good neurosurgeon. And so what your currency is as a physician are what are your outcomes. So never lose track of that, no matter what all the other distractions are. Round twice a day. This is key. I always tell people that you can do the world's best surgery, but you fly out the next day, people don't see you. They're not going to talk well about you. Meanwhile, you take out the world's smallest tumor, you see them twice a day for 30 seconds, and they think the world of you. So that interaction with the patients only encourages them promoting your practice. And I think that human touch of seeing them twice a day, whether it's for 5 minutes or for 30 seconds, makes a huge difference. And finally, happy patients means more patients. So I'm going to just talk about the growth analysis, because We looked back, we wanted to see in the state of Florida, we looked back at the Florida Health Database. It looks at all procedures, ICD-9 and CPT, from 2006 to 2018. This is a little bit old. We have to update it with the new data, but this gave us an idea of what was our growth, what were the benchmarks, and what were our competitors doing. So, this is the brain tumor growth volume here at UM. You could see in 2011, it was 200, which for a university brain tumor program is certainly below par. And you could see here, once we as a team, as a collective team, started instituting these protocols, you could see the explosive brain tumor growth. Currently, we're at over 1,300, which makes us the busiest brain tumor center in the country. And this just goes to show that everyone buys in, not only the surgeons, but the staff, the nurses, the ICU. Everyone has to buy into this. And if everyone has skin in the game, that's when you have that explosive growth that I was talking about earlier. Looking at the percentage of cranial surgeries, 2011, less than 0.5% of all cranial surgeries in Florida were done here at the University Hospital. 2018, nearly 5% of all cranial surgeries. So greater than 1,000% increase in just 7 years. And just for kind of perspective, Florida is the third most populous state in the country behind New York and California. And so that means for every 20 brain surgeries going on, one of those is happening here. And by brain surgeries, that also includes biopsies, it includes shunts. So it's an incredible number of surgeries happening here compared to what it was just 10 years ago. Destination center, which is the ultimate end goal. 2006, people were basically walking to the hospital 5 miles. By 2018, 45 miles. Again, shows how you market, how you outreach. You can't just stay local, but you want to form a true destination center of excellence. So where did the growth occur for us? More to that point, nearly a quarter of the growth was outside of South Florida. The growth was along 95. As I said, we focused on Broward and Palm Beach. We also went out to the West Coast, which was a huge boon for us. A lot of those patients out on the West Coast, very well educated, affluent, and they wanted an academic center. They just had no idea how to access it. Once we provided that access, then the floodgates opened up. And that's another point, is that a good way to look at it is access is everything. If you're trying to build a program, it doesn't matter how good you are. If there's no access to you, that program is never going to get off the ground. So how do we compare with other Florida hospitals? This is a little old, over 1,200. It's now over 1,300, by far the busiest program in the state and the #1 in the country. 35% of all brain tumor surgeries in Miami-Dade, 20% of all brain tumor surgeries in Broward, 20% of all brain tumor surgeries in Palm Beach. This is our market share analysis. You can see growing from 15% up to over 50% in 2019. And then finally, this is another key slide along with volume is power, because it's great to build a practice, but at the end of the day, you want to build a center of excellence. A practice is temporary. A center of excellence is permanent. And so what's your legacy? What is the crown jewel of anyone's practice? It's ultimately building a center of excellence that kind of feeds off itself. So again, what was the translation of all the volume I just showed you? What's the translation into a brain tumor center? So 200 cases up to over 1,200. We brought in advanced cutting edge techniques. We had very unreliable neuropathology back when I started. We now have 2 and getting a 3rd world-class neuropathologist. This is only possible because of the volume. We had been asking for neuropathologists for years. But like I said, hospitals, cancer centers, universities have 1 million people asking for stuff. And if you're doing 200 brain tumors a year, they're going to say, no, we're not getting you another neuropathologist. But when you're doing 1,300, they have no choice but to give you exactly what you want. We had 1 medical neuro-oncologist. We now have 4 and hiring a 5th, again, secondary to the volume. We had no brain tumor bank. We now have one of the largest in the country with over 3,000 cases. We only had 1 clinical trial. We now have 15 clinical trial portfolio on par with Sloan Kettering, MD Anderson, all the major centers. We had no dedicated brain tumor researchers. We now have 4 dedicated NIH-funded brain tumor researchers. We had 2 brain tumor publications back in 2011. This past year, nearly 50. Just shows residents, fellows, other faculty getting involved, and everyone kind of pitching in. This is certainly not a one-man show. No fellowship. We now have one of the few CAST-approved brain tumor fellowships. And then there was this growth opportunity, right time, right place. And with the appropriate effort and the appropriate techniques, we built a center of excellence. And as my first slide said, this is about brain tumors, but it's applicable to every single specialty of medicine. It's no different. These techniques all make a difference, and they all generate the influence to build that center of excellence. So want to give a shout out to my team, in particular, my fellows. I've been blessed to have amazing fellows. Fellows are the reason why we can run, 2 operating rooms at a time, and clinic and Gamma Knife, and really escalate that volume, is because the ancillary staff and the fellows play a huge role in terms of generating volume. Shameless plug for my book, which is The Business of Brain Tumors. This is a book that I wrote with our chief resident, Dan Eichberg, with a foreword by Robert Spetzler, who's a legendary neurosurgeon. This book summarizes everything that this talk just went over, but in more detail. Again, even though it says brain tumors, don't be turned off. It really is applicable to all parts of medicine. And with that, thank you so much. Really appreciate it, Brian and Edith, for inviting me.
Yeah, no, Rick, really a masterclass in how to build a specialty practice. If you don't mind, we just have a couple questions for you.
Sure.
I will let the audience know that the link for Dr. Komotar's book, so no one's hopefully not taking furious notes on all of this. Just buy the book. You'll get you can get all of this in a compact form, so you can help build your practice. But just a couple questions from the audience, Rick. The first one is, maybe this is directed towards neurosurgeons or perhaps introverts by nature, but what would you say to some doctors who are maybe less outgoing and don't feel comfortable about reaching out for CME or outreach in general?
Yeah, that's tough. That's tough. I mean, I would say that they have to get over it, right? I mean, that's, again, no different than any business. If you're going to start a business, which is what medicine is, you have to be willing to put yourself out there. And if you're if you're introverted and you don't feel comfortable, that's just going to always limit you. And you have to find some way to overcome that, because it's too competitive. There's too many options out there for any physician to really compete with. And if you're not going to put yourself out there, you're going to end up losing to the people who are outgoing and they are not introverted. So I don't know. There's no answer other than you just have to work on that, because it's going to really halt your career.
Understood. And then with the hospital, how did you work around insurance issues? If you're getting all of these patients, certainly some of them have insurance, maybe other ones don't. How do you work that through with the hospital to keep your volumes high?
So if I get referred a patient and we don't take their insurance, which happens, not seldomly, I will ask for the films to see if that patient actually needs surgery. So I'll look at the films free, and obviously just look at them and decide, is this surgical or is it not surgical? A lot of times patient wants to see me. We don't take their insurance. It's a small meningioma. It was discovered because they were in a car accident, asymptomatic. I'll call that doctor, and I'll call that patient, say, look, I don't take your insurance, but I looked at your films. You don't need surgery. I would just change insurances at your convenience. I'll see you next year with a new MRI. And that way you don't lose that patient. If I look at that film and it's clearly operative, a patient had a seizure, they have a large tumor with midline mass effect, I bring them through the ER, because that's legit. It's an operative brain tumor that's causing neurological decline.
Right. Got it. And then, do you find that a lot of the lessons that you've taught us here, do you think those are more receptive for people in private practice or people in academia? And perhaps this is a good question for the residents that you see coming out, the residents that are going towards private practice or the ones that are going towards academia, who's more receptive to sort of these things, and who are the people that really need to take it to heart?
I would say private practice. Well, I would say it's applicable, as I said, to everyone for sure. But in private practice, if you don't heed these techniques and everything that was covered here today, you will not succeed. In academia, there's that little bit of a buffer where there's call and there's like an internal network of referrals that can keep you alive. Are you ever going to thrive if you don't follow these? No. But can you survive in academia doing other stuff, research, your R01 grants, administrative, and just fly by? Yes. Private practice, you don't have that luxury. You need to build a practice and you have to cover your expenses. So I would say that people doing private practice 1000% have to approach this like a business, and they have to use these techniques. Otherwise, you're going to fall behind.
Yep, got it. I think that's my last question. Again, Dr. Komotar's link for his book is in the chat. Really appreciate you taking your time to talk to us, Rick. Thank you for being our first inaugural IIH practitioner lecturer.
Absolutely, man. True pleasure. Thank you, guys. Really appreciate it. Edith, good to see you. Take care, guys.
Bye. Okay. So just a few housekeeping items as we wrap up here. We do have our next lecture in our practitioner series here. So just highlighting that, the next one will be on dural venous sinus stenosis, and that'll be presented by Dr. Vasish Srinivasan from the University of Pennsylvania, and the moderator will be Dr. Gary Duckweiler from UCLA. So that lecture will be February 6th at 8:30 p.m. Eastern time, which is a time that's more receptive to our West Coast colleagues. In the chat as well, you can connect with us on LinkedIn or Instagram or Twitter. And if you have any ideas for a future lecture, please email us at info@iih-hub.com. That's info@iih-hub.com. Thanks everyone, and we really appreciate you for being here.